Well, hello, my name is Julius Wilder, and I have the distinct pleasure of interviewing a person who's really important to me in my life, a person who's been an important mentor and an example, a stellar example of a human being, a stellar example of a father and husband, and certainly a stellar example of a physician. And one of the reasons why I became a gastroenterologist, and that's Dr. Michael Mcleod. You are an awesome person, and you have been so important in my development as a medical student since I came here to Duke now 18 years ago. And so I'm really excited about the opportunity to interview you and to learn more about your experiences as we kind of reflect on the history of Duke GI. And of course, you were here many, many years ago, including going back to the times of Dr. Tyre, when the division was going through such tremendous change. Can you maybe tell us a little about what that experience was like and what that tradition was at that point in time?
Well, the GI division at the time I entered it was quite small. Dr. Ruffin, Julian Ruffin, was the original gastroenterologist coming back, or dating back to the late 30s, and he was approaching his retirement at that point. He still had 2, sometimes 3 fellows that mainly were doing clinical work with him, learning the clinical aspect of gastroenterology. Occasionally maybe doing some simple little drug study. And Malcolm Tyre was originally over at the VA, interested much more in research, and he was moved over to Duke probably 63, somewhere right around that date, with a focus on research. And it was the budding years of the concept of a physician scientist. And so research really had not been part of the GI division until he moved over. His interest was in bile salt, enterohepatic circulation down through the ileum, reabsorption of the liver, etc. And so Tyre was working with Leon Lack in the physiology department, and they were interested in doing research studies on bile salts. So that was kind of the setting, and Tyre was interested in starting to recruit fellows with research interest, which had not really been a part of GI up until that time. So that's when I started in GI at that point.
And where were you before you came here to Duke, and what brought you to Duke? What was it that kind of really drew you?
I attended the University of Florida. At that time, Miami was the only medical school. University of Florida was starting their first year, but you had to have a 4-year degree, and I was at the time, you could occasionally get in after 3. So I applied to Duke, came here as a freshman medical student. We're going back to 1956, and then finished in 60, took 2 years of residency in medicine, went into the Navy for 2 years. At that point, Stead called me, Eugene Stead, who was chair of medicine, and asked me if I would be chief resident when I came back. It was quite shocking for me to get that invitation, because the usual pattern was after your 2nd year of residency, go to NIH. NIH was increasingly important, funding research at that time. 2 years at NIH, then you come back and you become a chief resident. So I felt like the only reason looking back was Ruffin was approaching retirement. The idea was I had already expressed an interest in gastroenterology.
Oh, I see. Yes.
And so maybe he thought he could kind of groom me to fill Ruffin's space. I don't know if that was the case. But I did not feel like I particularly deserved that invitation, but I took it. It was a great opportunity. And then when I finished chief residency, 64, 65, I then went into the lab for approximately a year, looking at amino acid transport in hamster guts, but it was clear for me, although research was important in terms of helping me be a more critical bedside physician, it was not what got me up in the morning. It was not my passion. And so I took about 6-8 months of some clinical GI, and then suddenly, 1967, January, I'm on the faculty, and I'm in gastroenterology. So, But again, a very small GI department at the division at that time.
Were there challenging things in the division at that time with all the growth and changes, or were there challenging things for you at that time with all the changes that were occurring?
Well, I think my personal challenge was to accept the fact that I love taking care of patients and I love teaching. And the emphasis in the late 60s, early 70s with NIH funding and research was about 80% of people going into the department or in the department was doing research of some kind. About 15 to 20% of us primarily saw patients. So there was a more clear division. Later, the third path, doing clinical research and patient care, became more and more of an option. But initially, when I was there, it was like you either went left to research or right to clinical care.
Yeah.
And part of it personally was feeling like that I really a second-class citizen, because
Sure.
I just take care of patients.
Yeah.
And so this kind of pull toward doing research was there, but it was clear that was not my mission in life, not to be a researcher.
Yeah.
But yet I value that time in the lab. Stead always said, as he went around watching physicians practice, was that they were learning the wrong things so often, because they would do a certain thing, there'd be a certain result, and they would assume what they did caused the result rather than saying, maybe, maybe not, kind of thing. So the idea of bringing critical thinking to the bedside and bringing scientific thinking to the bedside, and also being strongly clinical based, but you needed that critical thinking. So it was a good experience, and I felt it was an important part of fellowship training to spend some time in research.
And when you came through Duke, with all this tremendous change, with the new emphasis on research and the changes in the structure of the division, there were also tremendous change within our society. We're talking about the 50s and 60s in Durham, North Carolina.
Yeah,
What was that experience like, coming from Florida, and how, how did the hospital and the health system and the division sort of, adjust with all these major societal changes at that time as well? What was that like?
Well, Durham was starting to recover from being a tobacco town.
Yeah.
I mean, when late 50s, early 60s, I mean, you literally, depending on what direction the wind was blowing, you could smell the tobacco coming out of Liggett and Myers and American Tobacco Company. As simple as going out to eat, you had to brown bag. There was no mixed drinks served. You couldn't bring in, you couldn't buy wine, etc. So you had to bring your little flask, and they would provide you with ginger ale at night. So it was fairly primitive in many ways when you think back, but again, we're looking back 50 years.
Sure, yeah.
Even simple things like, my wife coming from New Jersey, used to talk about, there's no bread here. And I said, no, you've got bread, whole wheat, white bread, cornbread. No, I mean, pumpernickel, I mean a variety of breads that, in the Northeast in a bakery would be just standard fare. So a lot of that, was what we had to live with at the point. I think the other part was what I realized looking back with all the stress and tension of the Vietnam War, the racial issues, and the fact the students on campus were closing down the Allen building at one point, etc. All that.
Brenda Armstrong, right? Yeah.
Yes.
Our colleagues, yeah.
Right. And I think what I was involved in was trying to find my way onto the faculty and establish my credibility as a gastroenterologist with what back then was not much more than 6 months of training. I was a good clinician, and I still feel that internal medicine you need to know to be a good clinical gastroenterologist. But anyway, that was a challenging time, and I felt very cloistered in a way that a lot of these social issues going on, I was aware of them, but my energy was into getting established as a clinician, etc. Plus my third child coming along, and later my fourth child coming along. So my family was expanding. so there was a lot of distractions for me.
Yeah.
So what was, I didn't go out and protest the Vietnam War. I didn't have energy for that, So,
What did you enjoy most about your time back then when you reflect on what it was like and the people you worked with and what you were able to do?
Well, I think that the exciting thing for me in the late 60s, 70s, and even into the early 80s, there weren't gastroenterologists in the communities, very few. And so we were getting pristine virgin cases of any GI disease you want to think about. And so it was exciting to see these, cases never diagnosed before. Case of Whipple's disease from southern Georgia, celiac sprue, etc. Even simple cases of ulcerative colitis. And and back then we were generalists. We weren't hepatologists. We weren't these
IBD
different
versus
exactly.
Yes, sir, yeah.
So we were kind of a generalist at that point in time. But the exciting part was the fact that we were seeing all this new virgin GI, never diagnosed or treated. And so it was a great teaching opportunity, learning opportunity. And when I came out of training, after my residency years, I was convinced also that all I needed was data, facts. Give me the lab data, the facts, the x-rays. And again, a reminder that all we had at that time was contrast barium studies. We could do an upper GI, we could do a barium enema, and that was the extent. We had a short proctoscope, 25 inches, and we had an esophagoscope that could look at the esophagus. Very limited gastroscope. But all that, kind of limited what we could do. But at the same time, it was like the patients, as I began to follow them, what I realized was things were starting, and these, for the first time, you're getting a longitudinal view of an illness.
Sure.
Because as a resident, you're just seeing intermittently. And you begin to realize that things were happening to these patients that you couldn't measure. Some got better when they should have died. Some died when they should have gotten better. And you're sitting there and saying, what is going on? And so you start to recognize the kind of psychosocial dimensions of the mind-body connection. And seeing people with atypical chest pain, irritable bowel, etc. And so you begin to recognize also that you had people with organic disease, like I had mentioned to you in the email. The ulcerative colitis, who's also got irritable bowel. And he doesn't need 50 milligrams of prednisone. Or the reflux patient who's refractory because he's also got panic disorder. So you begin to see this overlap kind of thing. And then the thing I would also really preach to the fellows is, because an IBS has had it for 20 years and they come in now with their colon cancer, you've got to be able to take a clear history and recognize, hey, something's different here. This is not the usual IBS kind of thing going on. So that's the part I love too, is this my waking up to the fact that it's not just all what we can measure. It's as exciting as all that is, there's this other whole human dimension that we have to bring into kind of the picture, kind of a holistic view.
It's very different, the way you trained versus the way I trained, for instance, and how the practice has changed over time, as you alluded to. We have more specialties now and sort of areas that we specialize in as opposed to being more generalists in GI, as you described. Do you think that's an advantage or a disadvantage?
Well, I think it's both and. One of the things I've learned in my life is that, growing up you feel like, well, there's a right answer and there's a wrong answer. It's just that simple. But as you go along, you realize that, well, this is right most of the time, but this is right sometimes. It's like the example I would use is pride and humility. Well, pride can lead to arrogance. Pride can give you confidence to go out and take a risk and do something. Humility can create appropriate humility, even when you've learned something, you've got more to learn. Or humility can create passivity. So pride and humility each can have a role in your life depending on where you are. And so I think the specialization, you know, the advent of molecular biology as it was coming along, all that is incredible. And, you know, look at what happened with hepatitis C.
Right, yeah.
Wonderful, wonderful example of that.
Absolutely, yeah.
But at the same time, I think there is a risk of losing kind of the holistic view that when you're working with a patient, they have much more going on than just their molecular events, biology, so to speak.
Yeah.
They've got a mind and their emotional and spiritual life that's affecting the biology. I recently did a talk at Ali on the role of mindfulness in changing genes. You can turn genes on and off, the epigenetic mechanism, you know, and it's a beautiful example of starting with stress up here, going through psycho, you know, the psychoneuroimmunology, endocrinology, all the, you know, the molecular part down to your genes, and how all that's interconnected. Now you know that generally, but the question is, can you bring it to your patient?
Sure.
You know, and somebody's not responding like you think, what else is going on in their life? I mean, that's the question. How is this affecting your life, kind of thing?
That's so very thoughtful, and I agree. And actually, I'll tell you, one of the things I've always admired about you, and one of the things I've taken from you in my training, was the idea to look at the whole patient and to consider mindfulness and all the various issues beyond just that one pathophysiological issue in terms of the care of the patients. You know, when I'm providing that care,
right?
And was an inspiration for my PhD actually as well.
Yeah, well,
so,
great,
you
great,
definitely
yeah.
have sort of spread that.
And I think, you know, I think. You know, I think there's the technological part of medicine, you know, the skills of using our instruments and endoscopy, et cetera. For me, that came along after I entered GI. You know, it was something that John Garbett came on, and he and I, we kind of had to learn that together. And it became a tool to use, but it wasn't our primary goal. It was where could it help us kind of thing. But then you had the scientist part, being critical in your thinking, and of course that became increasingly the whole field of molecular biology, et cetera. And then there was the art of medicine, you know, of being able to see this whole person and recognize that, you know, when something's not working like you think, maybe we need to back up and take a look at the whole situation, kind of thing. So art, what I call being an artist, the artist of the art of medicine, kind of thing. But also a scientist and also a technician. Several years ago, Paul Killenberg and I went out and interviewed several of our graduates who are now in their 50s, and we were going out on a fundraising adventure kind of thing for the Killenberg-Mcleod Fellowship. And as we talked to them, they said, you know, we're recruiting GI fellows to come. We need new people in our practice, but all they want to do is endoscopy. They don't want to follow patients. And so again, that to me is a potential downside if you get focused only on the kind of technological part of medicine. And again, it's why are we in medicine, kind of thing. And medicine's a very seductive profession. It dangles all these little gold stars and trophies and things out there, and I think it can lead us astray from what is that core truth we carry. What is my passion? What's my purpose? And it may well be research and whatever. On the other hand, you can get off track, I think.
So reflecting on that, then, what if you were to talk to our new GI fellows, our current GI fellows, and, you know, thinking about what your experience has been like and the things that you have learned, you know, what might be the advice, some of the things that you want to tell them to make sure they're aware of as they sort of embark on this career in gastroenterology?
Well, I think for myself, I remember, as I said earlier, coming out of my training and just being, you know, it was like the old Marine, you know, work hard, persevere, know every single journal article coming out, et cetera, know the data, and then the realization as you see patients. Now, the problem is if you go immediately into research, et cetera, you may not ever have that experience. But if you start following patients longitudinally, you begin to see these other elements, the so-called, the mind-body elements that are there in all of us,
Yep.
you know.
Yes, sir.
The other part of this, I think, is that this connection you begin to form with the patient also feeds you. It feeds why you're in medicine, at least for most of us, kind of thing. And so there's a mutual exchange. The patient feels cared about, valued, etc., and you feel valued for what you're able to bring, kind of thing. And I think a lot of the burnout that's happening in general medicine, not necessarily GI, is because of the increasing compression of time involved. There's less and less chance, and the computer comes in, you've got to deal with that. There's less and less chance for that interaction to occur. It's the I-thou connection, you know, that we, if we're not careful, we make it I-it. And this patient becomes an object that we've got to fix, and it becomes a machine. So we can, you know, find the right part, tune it up, etc. But the patient walks out of there feeling like he's not really being seen or heard, kind of thing. So I think I say that's important. Not only, you know, the problem is you're wanting to get ahead, establish yourself, get that fellowship, whatever, write that paper. All that's important.
Sure.
But the risk is, are you losing parts of yourself that you originally brought into medicine? And the part that feeds you, kind of thing. I think it feeds you in terms of that personal interconnecting part, the I-thou connection.
Absolutely. Well, that's wonderful. Thank you so much for your time, Dr. Mcleod, and thank you for being an important person in my life as a mentor and inspiration.
Yes, well, it's been fun. When I think back to our first year back in practice course,
that's right, yeah, way back
you were first year. I was actually, I think that was my first year in practice course.
I didn't realize
after
that.
I had retired. I retired in 2000. So, and then to see how you helped us in practice course when you came and gave your talks. It's been a wonderful experience for me to watch how you've grown, evolved, etc. Yeah,
Well,
it's been wonderful.
Well, thank you for your time today.
Absolutely, absolutely.